Hello, my name is Lisa Elliott, and my presentation for Professor Lauren Deaton's class in History of Psychology at UT Tyler is Schizophrenia from its Inception. This presentation examines the definition, origins, diagnostic development, and treatment history of schizophrenia from its earliest recorded descriptions to the present day. I will also discuss how societal attitudes and scientific advancements have affected our modern-day understanding of this disorder. What is schizophrenia? Schizophrenia is defined as a chronic and severe psychiatric disorder characterized by disturbances in thought, perception, emotion, and behavior. However, I want to emphasize that it is located on a spectrum, and it isn't easy to diagnose. It's a very complicated disorder. It has been a hard challenge for cross-cultural clinicians and societies throughout centuries. According to Saha and colleagues in 2005, it only affects about 1% of the global population, but its impact on individuals, families, and healthcare is profound. It typically becomes apparent in late adolescence or early childhood, a period that is crucial for social and occupational development, with symptoms that are associated with major functional impairment. So early detection and intervention is critical for both the people afflicted with it and also those around them. Therefore, it is crucial to make sure that the diagnostic criteria in the DSM is carefully observed for an accurate diagnosis. Diagnostic criteria. The DSM-5-TR, which is the most recent DSM edition, requires specific criteria for diagnosing schizophrenia. A person must show at least 2 of the core symptoms for a significant portion of a 1-month period, and at least one of these must be delusions, hallucinations, or disorganized speech. These symptoms fall into 2 broad categories: positive symptoms and negative symptoms. There are also additional criteria such as significant reduction in the individual's level of functioning at work, in relationships, or self-care. And the symptoms must persist for at least 6 months, with criterion A symptoms for at least 1 month out of those 6 months. It's important to note that a diagnosis of schizophrenia cannot be made from just one symptom. It takes time and a holistic approach of evaluating a host of positive and negative symptoms. Positive symptoms reflect an excess or distortion of normal functioning, while negative symptoms represent a reduction or loss of normal emotional and behavioral capacities. Positive symptoms are among the most recognizable features of schizophrenia. It involves the presence of experiences or behaviors that are typically not observed in healthy individuals. In other words, they are added behaviors that are not usually seen in the majority of people. Delusions are false beliefs that individuals continue to believe, in spite of evidence to the contrary. Hallucinations, most commonly auditory, involve perceiving sensory experiences without external stimuli. Disorganized speech reflects disruptions in coherent communication, often characterized by derailment or incoherence. Additionally, grossly disorganized or catatonic behavior may be present, ranging from unpredictable agitation to a marked decrease in reactivity or response to the environment. These symptoms reflect disruptions in thought processes and perception, and they often contribute to significant distress and impairment. Negative symptoms, on the other hand, represent a reduction or absence of normal emotional and behavioral functions and often contribute more to long-term disability than positive symptoms. Diminished emotional expression includes reduced facial expressions and eye contact. Avolition involves a significant decrease in motivation to initiate and sustain activities, such as work or self-care. Alogia is characterized by reduced speech output, often reflecting impoverished or poor thought processes. Anhedonia refers to a diminished ability to experience pleasure from activities that are usually enjoyable. Finally, asociality involves a decreased interest in social interactions. These symptoms tend to be persistent and are sharply associated with functional impairment, making them critical components of schizophrenia's clinical presentation. Now that we have discussed what schizophrenia is, we can discuss its origins and some historical figures that influenced the development of our knowledge of it. The earliest descriptions of schizophrenia first appeared in ancient Egyptian, Hindu, and Chinese records. Symptoms included unusual behaviors or perceptual disturbances, and they were lumped together with other disorders such as depression. They were believed to be caused by supernatural forces. Yet, in classical Greece, Hippocrates, ahead of his time, proposed that mental disturbances were caused by imbalances in bodily fluids called humors, particularly within the brain. His concept of phrenitis reflects an early biological understanding of mental illness. Despite Hippocrates' theory, the Middle Ages still engaged in supernatural explanations for mental illness. Individuals exhibiting hallucinations or disorganized behavior were frequently labeled as possessed or morally corrupt. Treatments included exorcisms, religious rituals, and confinement. These practices reflected the limited scientific understanding of mental illness at the time and contributed to the additional problems of discrimination, stigma, and mistreatment. Then came the Enlightenment period, which marked a gradual shift toward more humane and medicalized approaches to mental illness. Physicians, such as Philippe Pinel, advocated for moral treatment, focusing on compassion, structured routines, and the removal of physical restraints. Asylums expanded across Europe and the United States, though conditions varied widely. This period laid down the foundation for modern psychiatry, even though scientific understanding remained very limited. A major turning point occurred in the late 19th century with the work of Emil Kraepelin. Kraepelin introduced the term dementia praecox to describe the disorder characterized by early onset and progressive cognitive decline. He argued that this condition was a distinct biological disease that was separate from manic depressive illness. Kraepelin's classification system profoundly influenced psychiatric diagnosis and remains foundational to modern nosology, the classification and naming of diseases. In 1911, Swiss psychiatrist Eugen Bleuler introduced the term schizophrenia, meaning split mind. Bleuler emphasized that the disorder involved a fragmentation of mental processes rather than a literal split personality. He identified the 4 A's: affect, associations, ambivalence, and autism as central features of the disorder. Bleuler's conceptualization broadened the understanding of schizophrenia and remains influential today. The DSM-1, published in 1952, labeled the disorder as schizophrenic reaction, reflecting a psychoanalytic belief that symptoms represented a maladaptive response to psychological stress. The criteria was vague, and diagnosis was highly subjective. There were also subtypes of schizophrenia such as paranoid, hebephrenic, and catatonic forms were included, but the definitions of these lacked precision. DSM-2 removed the term reaction, but maintained a mainly psychoanalytic influence. Criteria remained broad and unspecific, contributing to inconsistent diagnoses. The manual expanded subtypes and included simple schizophrenia, a category that was later removed due to poor reliability. The lack of operationalized or measured criteria contributed to significant diagnostic inconsistencies across clinicians and across countries. DSM-3 marked a dramatic change in biological psychiatry and in scientific accuracy. It introduced explicit, operationalized criteria, required 6 months of disturbance, and defined 5 core domains of symptoms. These changes dramatically improved diagnostic reliability and moved the field away from psychoanalytic interpretations. Subtypes were still retained, but were more clearly defined. DSM-3R refined the criteria even more. It clarified ambiguous language and increased emphasis on negative symptoms. Adjustments to impairment requirements and symptom descriptions improved consistency across clinicians and addressed the criticisms of the inflexibility of DSM-3. The DSM-4 relied heavily on empirical field trials to refine the diagnostic criteria. It retained subtypes and required evidence of social or occupational dysfunction. Exclusion criteria were clarified to improve diagnostic accuracy, particularly in distinguishing schizophrenia from mood disorders and from substance-induced psychosis. The DSM-4-TR did not alter diagnostic criteria, but it did update descriptive text on prevalence, course, cultural factors, and comorbidity. This addition served as a bridge to DSM-5, maintaining stability in diagnostic practice while incorporating new research findings. The DSM-5 eliminated all schizophrenic subtypes due to poor reliability and limited clinical effectiveness. It introduced dimensional symptom severity ratings, clarified negative symptoms, and strengthened criteria for catatonia. These changes reflected modern neurodevelopmental research and emphasized the heterogeneity of schizophrenia. Which brings us to DSM-5-TR. DSM-5-TR refined diagnostic language, updated cultural considerations, and expanded the definitions of delusions and hallucinations. It also incorporated new research on suicide risk and comorbid factors. While the core criteria remained unchanged, these updates enhanced clarity and diagnostic precision. So, moving on to the historical treatments for schizophrenia. Before the 20th century, treatments for schizophrenia were often ineffective and sometimes harmful, what we would now consider abusive. Interventions included religious items like charms and religious rituals, bloodletting, purging, restraints, and long-term institutionalization. The moral treatment movement offered some improvements, but scientific understanding remained limited. The early 20th century saw the emergence of biological treatments. Insulin coma therapy, introduced in the 1930s, involved inducing comas through high doses of insulin. Electroconvulsive therapy, or shock treatments, developed in 1938, was initially used to treat schizophrenia before becoming more associated with mood disorders. Lobotomy became popular in the 1940s, and it involved surgically severing connections in the frontal lobes of the brain. These treatments reflected attempts to address the biological causes of schizophrenia, but unfortunately, they also resulted in severe side effects. But then, a major breakthrough occurred in 1952 with the introduction of chlorpromazine, the first antipsychotic medication. Chlorpromazine reduced hallucinations, delusions, and agitation, revolutionizing psychiatric treatment. This development contributed to widespread deinstitutionalization, as many patients could now be treated within just the community. Beginning in the 1990s, second-generation antipsychotics, such as clozapine, risperidone, and olanzapine, became widely used. These medications offered improved tolerability and reduced motor side effects as compared to earlier drugs. Meta-analyses demonstrate that second-generation antipsychotics are beneficial for many people with schizophrenia. Currently, treatment for schizophrenia usually involves a combination of medication and psychosocial interventions. Evidence-based approaches include cognitive behavioral therapy, or CBT, for psychosis, family therapy, social skills training, and supported employment. Early intervention programs, such as coordinated specialty care, have demonstrated significant improvements in the outcomes for individuals experiencing first episode psychosis. Schizophrenia has long been associated with stigma, misunderstanding, and discrimination. Media portrayals often exaggerate dangerousness or unpredictability, which contributes to public fear. Cross-cultural research reveals that the content and emotional tone of hallucinations varies significantly across cultures, highlighting the importance of cultural context in understanding the disorder. Contemporary research conceptualizes schizophrenia as a neurodevelopmental disorder, influenced by genetic, biological, and environmental factors. Dopamine dysregulation, brain structural differences, and early developmental irregularities all play significant roles. The stress vulnerability model insinuates that people with genetic predispositions may develop symptoms in response to environmental stressors. In conclusion, the evolution of schizophrenia reflects a complicated interplay of cultural beliefs, scientific progression, and evolving treatment practices. From ancient supernatural explanations to modern neurobiological models, our understanding of this disorder has progressed dramatically. While significant challenges always remain, particularly with regard to stigma and access to care, ongoing research continues to improve diagnosis, treatment, and quality of life for those who are having to live with schizophrenia.